Some 57 million rural Americans depend on their hospital as an important source of care, as well as a critical component of their area's economic and social fabric. But in many areas, there is growing concern that fabric is starting to fray. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hetterly with AHA Communications. The stresses of the past 2.5 years have affected every hospital and health system in America, none more so than rural hospitals. On this Leadership Dialogue Series podcast, AHA Board Chair Wright L. Lassiter III is joined by Dr. Julie Yarrow, president of ProMedica Charles and Virginia Hickman Hospital in Adrian, Michigan. Lassiter and Yaroch talk about the issues that rural hospitals continue to face, including workforce shortages, increased costs of care, and an aging population. At the same time, patients living in rural communities must navigate challenges related to accessing care, such as lack of transportation and unreliable or unavailable internet access. Yarrow says collaboration is key right now. She describes how the hospital she leads views healthcare as a team approach and talks about its vital role as an anchor institution in the community. Let's join them.
Thank you, everyone, for joining me today for another Leadership Dialogue session. I'm Wright Lassiter. I'm the CEO of Common Spirit Health and the Board Chair of the American Hospital Association. I'm excited to be with you today and excited to continue our dialogue with amazing leaders from across the country talking about topics of interest. Today, I look forward to our conversation as we focus on a very important topic, and that is rural health. I think as we all know, we've seen across our nation's rural hospitals, we know that they play a critical role in caring for many communities throughout the United States, and they certainly played a critical role during the pandemic. We also know that rural hospitals and rural healthcare systems face unique challenges in caring for patients resulting from geographic and staffing shortages to patient mix and patient volumes to recruitment of key talent. As in all communities, hospitals serve as a crucial resource to promoting both health and well-being. And we've talked earlier on this show about how the pandemic has increased the existing challenges faced by rural healthcare organizations as they work to meet that mission. In the last 10 years, more than 140 rural hospitals have closed, and another more than 400 rural hospitals across our nation have indicated that they are vulnerable to closure, which would certainly reduce healthcare access and access to healthcare services for many Americans, and frankly, far, far too many. Currently, close to 50% of rural hospitals report having negative operating margins. I mentioned these data points just to highlight and to offer a small snapshot of the reality of rural healthcare, with the pandemic exacerbating struggles for our rural hospitals. It's vital that we figure out how do we strengthen and how do we sustain this vital sector of our hospital network. And that's why I'm so pleased to have a leader with us today to talk about the reality of delivering healthcare in rural America. And so I'm pleased to introduce and to join me today is Dr. Julie Yarrow. Julie is president of ProMedica Charles and Virginia Hickman Hospital, which is a 58-bed rural hospital located in Adrian, Michigan. She also serves as the senior vice president of inpatient and retail pharmacy for ProMedica Health System. Dr. Yarrow practiced internal medicine for 15 years before taking on a full-time role in administrative work at Hickman Hospital. Julie also co-chairs the Michigan Health and Hospital Association Public Health Task Force, as well as sitting on the American Hospital Association's Rural Health Services Committee. Charles and Virginia Hickman Hospital is part of ProMedica Health System, a mission-driven, not-for-profit organization that's focused on improving health and well-being of people and communities across Northwest Ohio and Southeast Michigan. So please join me in welcoming Julie, and let's get right to our conversation. Julie, thanks for being with me today.
Yeah, my pleasure to be here.
So, Julie, as I mentioned earlier, there are just a multitude of challenges threatening the stability of rural hospitals. Tell us about distinct and unique challenges that you face in a rural community where you serve.
And I don't know if there's distinct differences between rural and urban. I think the more that we communicate and learn from each other, we're all struggling in similar areas currently. But I think even prior to the pandemic, recruiting has always been a huge challenge in rural communities. Typically, 90% of my frontline staff live in the community that we serve, and that culture has changed, particularly with the new graduates that are coming out. And when we are interviewing candidates for this region, you know, they really want convenience. They want resources available to them that many of our rural environments can't support, such as simple things like takeout, childcare. I will say Amazon has really helped us sell some of these things as people can order things online. But even those simple things that give that work-life balance can be a challenge for us in the recruiting world. But more importantly, back in the days when I first came out of school 25 years ago, we saw more single income families. And as we are looking particularly at our providers, they're dual income. And often it's a struggle in a rural environment for us to find a job for that spouse. That can be one of our greatest challenges, and that occurs even in our nursing areas. The other piece, too, is our pipeline for talent has changed dramatically. We have 2 small colleges in our community. We also have community colleges, 2-year programs, and they have really shifted the direction of their educational programs. So we used to get a huge pipeline of frontline staff related to pharmacy techs, surgical techs, lab technicians, and we're not seeing that same volume coming out. So our resources have really diminished, which makes it more difficult for us. And then also in recruiting, our schools have shifted. We saw a huge influx of students going from being general internists and primary care to being specialists. And when you're in a rural community, we really need to focus on general internal medicine, those folks that see cardiology, pulmonary, critical care. We need family practitioners that deliver babies. And so that has really hurt us as we've seen that population of residents coming out dwindle. Transportation would be another piece I would say is a huge challenge in rural healthcare. My site covers 750 square miles. I have an increasing aging population. Most rural communities are seeing that older generation staying and the younger leaving. And so access to care is a huge limitation. We don't have Lyft. We don't have Uber. What taxis? So I have 2 taxis in my community, and they're not 24/7. So that is difficult for our patients to get access to care. It's also difficult for me to look at models where we do travel nurses because of the windshield time. So when you have diminished staffing models, it's really hard to have a traveling nurse that spends an hour in one direction just to get to a single patient when I can use them in a better capacity inside the 4 walls of our hospital. So I think that is a huge challenge in rural America and an area that doesn't have as many options that I see with my urban counterparts. And then, lastly, the third thing I would hit on is bandwidth. So we're probably going to talk a lot about with technology and telehealth, acute care at home, and bandwidth is a struggle in rural areas, and just the technology that's inside the 4 walls of the patients of the community that we need to serve. We hear a lot how people went to remote access or virtual jobs at home. Many of my employees that we would have deployed out at the height of the pandemic actually asked to come back inside our 4 walls because of internet. They didn't have high-speed internet. It increased the amount of time for them to complete their job. They were falling behind in tasks. So the bandwidth has affected our ability to look at creative solutions out in the community, but also allow my employees to do that hybrid model of working inside 4 walls and working at home.
Well, I would just say that we could stop and just unpack that answer and fill up the full time for our leadership dialogue today. I really appreciate the comprehensiveness of the challenges you mentioned. 2, highlighting that some of the challenges you mentioned aren't necessarily unique to rural versus urban. They're just exacerbated in some way, shape, or form. Technology challenges certainly is one that impacts both urban and rural. there are unique differences and maybe between an urban environment and a rural environment. But I think your point is really well stated. So thanks for sharing. Let's just turn to a moment. I mentioned about the number of facilities that have closed. I mentioned how many have negative operating margins, and mentioned that there's a lot of financial strain. And so clearly advocating for financial sustainabilities of all hospitals, including rural facilities, is a key priority for the American Hospital Association. And we know that, frankly, our financial pressures will continue to mount as we get further and further from the initial phases of COVID into what is this new form of life outside of it. Can you just share a little bit about the unique financial pressures or the financial pressures that your organization is facing, and then that may be unique to your facility, it may be unique to ProMedica, or it may be you may have a lot of things in common with other rural facilities. But maybe just talk a little bit about challenges you're facing, and if there are any policy changes that you might think of that could help rural hospitals like yours have greater financial stability.
So again, probably a common theme amongst all facilities, from financial strains, supply chains, agency costs. The cost of care has gone up, and what I try to do with my new board members is try to explain to them there isn't a rural pricing and an urban pricing. A CAT scan costs the same no matter what size of facility. I'd say in our smaller facilities, it just takes a lot longer to get a return on our investment when you're only doing a few hundred cases a week versus thousands of cases a week. I mentioned earlier the aging population that we're seeing in rural America. And what that means is we're also seeing then more state payers be our primary source of insurance, Medicare, Medicaid. Our commercial payers are getting smaller and smaller in many of our rural communities. And so it's getting harder to cover that cost of care. Assistance programs like Medicare dependent sites are key for rural hospitals, hospitals that are under 100 beds. If we were to lose that would be a huge financial hit. And what that forces us to do is look at service lines we can no longer provide. So again, we've talked, buzzword is health equity, right? And access to care. And rural sites provide those access points that are critical for folks. I think as we look at the increasing Medicare population in rural communities, we really need to challenge Medicare to adjust their pricing to cover the costs that have been rising in all of our hospitals. Otherwise, as you mentioned, those statistics of the number of closures, those are only going to continue to increase, and access is going to be a challenge. And we know as healthcare has evolved and we have technology that can save lives, minutes matter. And when people are having to take longer drive times, we're going to have worse health outcomes in our communities. That's been a big piece of that. I think, low volume hospitals, that's been a huge issue. During this pandemic, a lot of your rural hospitals saw higher acuity care. A lot of those were being transferred out. So that could have affected programs like your 340B program, where they couldn't hit that Medicaid volume that they once did. And it was because it was the right choice for the patient to transfer them out. Or those of us who belonged in systems kind of shifted our focus that certain hospitals were our COVID hospitals while others took care of those non-COVID patients. And that affected our 340B eligibility. And those programs are not just vital to rural hospitals, they're also vital to urban. But as volumes continue to shift in rural, as there's more and more programs that are based on volume, it's going to be difficult for rural hospitals to meet those metrics. And those cuts are going to be take a huge impact on how our operations are. Historically, rural hospitals have focused on grant funding, and they have focused on foundation dollars. And our foundation dollars for all of us are getting more limited as people still give, but they don't give what they used to. And in rural sites, a lot of those industries we once have, auto industry in Michigan was huge, but a lot of our factories have left the rural sites, and that has really affected my community support or what they're able to do. So that's impacted, financial resources that we once historically had that we don't anymore.
So your organization is part of ProMedica, as I mentioned earlier. And I know that, in some communities, rural hospitals are independent. Sometimes they're owned and operated, managed by municipalities. In some cases, they're parts of regional systems. In some cases, there are standalone not-for-profit entities. So maybe talk a little bit about the experience of being part of a system and the benefits of that affiliation. And we certainly know that that there may have been unique things that occurred because you were affiliated with the system during COVID. And so talk a little bit about what that affiliation is like being part of a system as opposed to being a standalone rural facility.
So as supply chain costs go up in all industries, being part of a larger organization, buying power, right? So the larger you are, you can negotiate contracts that can cut costs. So, being part of ProMedica has allowed us efficiencies on keeping those costs down, not just, in gloves and orthopedic supplies, but in pharmaceuticals. So that's a huge piece. And I would say there's a lot of freestanding rural hospitals that if you're not part of a system, looking at collaborative efforts that can also address the power of numbers and negotiating those contracts with vendors, I think has been key for us. Subject matter experts. So, when you're in a smaller hospital, we have one person that wears many hats. And being part of a larger system has given us greater access to marketing, legal, 340B team. A rural hospital have a single 340B team that is well-versed in all of the legalities of that, I think is really difficult. I mentioned grants earlier. So again, larger organization, you have a greater grant team. And I think that's allowed us to capitalize and receive some financial relief that we wouldn't have if we were not part of that. But, more importantly, I'm lucky enough that during this pandemic in the September of 2020, I opened a brand new hospital. So we closed down 2 smaller rural hospitals that had aging infrastructure that could not support the technology or was not a work environment that attracted top talent. If I was not part of a larger organization, I don't know if we would have been able to complete that project. So that is a huge benefit to the community. And then the other piece too is just everything from a system perspective we can do related to social determinants of health. We're an anchor institution, and being able to be part of a larger institution, I think I'm able to do more on that front.
Public health resources. As hospitals have all had unique experiences during the pandemic as it relates to serving in various public health roles in their communities. Many organizations have had to expand their public health role and serve more as anchor organizations, whether they wanted to or not. Again, your parent is part of a healthcare anchor network, and so it sees itself as being broader than just being a hospital. Maybe talk a little bit about how you worked as a trusted community partner to convene other stakeholders to help improve health and well-being, and then also know that you all have some unique partnerships in your community, like with the YMCA and others. So just maybe talk a little bit about what it's been like as a community partner, doing things, frankly, probably broader than maybe the historic role of the hospital in the communities that you're serving.
Yeah, so collaboration's key right now, right? I always tell our board that healthcare is a team approach, and taking care of a community is a team responsibility. So we can't have one entity that does it all, particularly as we realize healthcare is more than just writing a prescription and filling it. It's addressing a home environment, other social determinants of health, making sure our patients have a healthy environment to live in. And that really relies on partnerships throughout our community. So I think, many of us in all of our communities are our largest employer. We have a stronger voice than many in the communities that we serve. And so that's allowed us to leverage our position as an anchor institution and helping secure resources in our community. You mentioned the YMCA. That's been fantastic. Again, they had an aging infrastructure. Our new campus is on 130 acres. We had space. It also was a unique collaboration to form between our rehab services and our dietary education with the YMCA. So we could share space and increase the amount of services we could provide in the community that we weren't able to do historically. One other piece that we've been able to recognize is, in rural communities, we also have socially vulnerable communities. So areas where there's significant health inequity, we have migrant workers, we have areas that have housing struggles and technology struggles. And so we have formed a collaborative effort with others in the community to form what's called the eBide 2 Institute that we're hoping to go live with later on. Mm-hmm. And really that's a hub where we can form collaborations, where we can share data, mm-hmm. where we can provide resources to the community where they would have to go to multiple stops and now they can come to one location. We can increase our programming, our education. During this pandemic, I think a lot of us in healthcare, our eyes were opened up to the lack of trust that many of our community members have in healthcare. And so some of these efforts are to regain that trust in the community, to help increase access to resources that have always been there, but people weren't aware of them. So I think as being an anchor institution, we have that voice to raise awareness in our community, but also help form collaborations that improve our community going forward.
So, I say this at the end of each of these dialogues that we could keep talking for another hour. We try to keep these relatively brief just to make sure that we don't lose our listeners. There are so many more facets we could talk about related to rural health. The critical issue is this: as a country, we need to ensure that we have access to health in every community we serve. And as you said, whether that be rural, urban, suburban, or otherwise, we need the fabric of healthcare that allows every one of us to be able to live our best lives. Julie, I want to thank you for joining us today. It's been a fascinating conversation. I would tell you that I attended my first National Rural Healthcare Conference earlier this year in my role as the AHA Board Chair and got so much out of listening to leaders like yourself. One, talk about some of the unique challenges, but more importantly, as you indicated, highlight that the challenges in rural health are not different than other parts of our healthcare ecosystem. In some cases, they're exacerbated. In some cases, they're a little more complicated, but they're the challenges that we face across our field. Would just say that your insights on rural health have been very helpful to our audience, and I'm sure that they will enjoy our dialogue, and I look forward to having some additional conversation with you about how we can do better to shore up the fabric of healthcare across our nation, and in particular in rural healthcare. So until next time, thank you everyone for joining me today. I hope you're back next month for our next Leadership Dialogue. Thank you very much.